Great. Well, thank you very much, Hugh, and thank you for the invitation to be here today. I'm very excited to talk about one of my pet subjects. So delighted to be joining you all today, and also to be joining my two panelists to talk about this topic: Rob Sloan, who's head of services at Shift MS, and Gemma Grant, who's the digital learning designer and MS patient advocate. So just very briefly about Rob. Rob is a multidisciplinary designer with a passion for applying design thinking to real-world problems. And he's been with Shift for over 5 years, focusing on the needs of people recently diagnosed with MS and the challenges of having a long-time condition, and how to use design and tools to improve the service and measure the impact of this. So I'm going to be talking first and then handing over to Rob. And then Gemma is going to be talking more from the from the perspective of somebody who has MS. She was officially diagnosed in 2010, having suspected she had MS since 2008. And she's also being diagnosed with generalized anxiety disorder, premenstrual dysphoric disorder, and depression. So she's had a lot of experience in this area. She's a vociferous information hoarder, so she's going to be sharing lots of really interesting information with us, but also some of her own experiences of accessing some of the therapeutic services that I'll be telling you a little bit about as well. So hopefully we're going to talk from my perspective as somebody who's been researching in this area for over 20 years, as well as a clinician, Rob's as a designer, and as somebody coming from Shift, which is, for those of you who don't know, is a patient-led, patient-driven charity for people with MS, and then Gemma from her perspective of somebody who has it. So I'm going to now try and quickly share my slides with you. So as I said, I'm going to be talking about anxiety, depression, as well as the concept of distress in long-term conditions. So very quickly, I'll be covering why I think this is very important, why I think we need to be doing it a lot better than we're currently doing it. I'll talk a little bit about more traditional methods of CBT for depression, as if it was a primary mental health problem, and then perhaps where this sometimes falls down in the context of understanding distress in an illness like multiple sclerosis. I'm going to then talk to you about the possibility of IAPT and how we could build this better than it currently is as a pathway to treat distress. And then a little bit of work that we've been doing in the last 3 years about a digital program called Compass, Navigating Your Long-Term Condition, which is for treating distress in the context of having a physical long-term condition. So why do we need to be better at this? Well, if you look at a recent meta-analysis that was published a couple of years ago of 58 studies, and this is always the difficulty because when you look at different studies, you see slightly different prevalence rates. But if we look at the average, if we accumulate all the data that we have across studies, although there is quite a lot of variability, the pooled mean for depression is almost 30% of people with MS and 22% of people with anxiety. So these rates are high, much higher than you find in the general population. And importantly, and this is what I want to talk to you a bit about, is distinguishing between depressive or anxiety symptoms compared with a defined mental health disorder. And if you look at the former, you have particularly high rates. Then therefore around 35 to 34% of people have significant symptoms of depression and anxiety, and smaller amounts will actually meet criteria for a mental health disorder as you would define it within the context of primary mental health and things like the DSM. So in terms of having something like a phobia or generalized anxiety disorder or major depression. So in terms of health services, for those of you, if you run services or whatever else, one of the difficulties that I often have as a psychologist is they say, well, you want to include this, where we're going to get the money from, who's going to deliver these services? Well, the cost of not doing it is actually very high. So if you look at a report that came out by the King's Fund, if you have people with long-term conditions, it's not specific to MS, this is any long-term physical health condition, who do not have anxiety or depression, the cost is very much less than somebody who does. So it costs almost 60% more to treat people who have a long-term condition and who are both anxious and depressed. So in other words, this is not the anxiety depression treatment, it's just the overall treatment costs. So the cost of mental health comorbidities to the NHS is estimated to be over 10 billion a year. Now, we know from across studies that psychological interventions reduce care costs by 20%. So there's potential saving of over £1,000 per patient and about 5.7 billion in total. So if we can free up the 5.7 billion to spend to get better integrated care, better psychological care for people, at the end of the day, we should at least be cost neutral. So yes, we can find money because we will hopefully save money, but you've got to spend it first before you can save it. So that's just my kind of little, for anybody who's trying to kind of develop services, because it's my ongoing frustration that it just doesn't happen. We've been doing this for 20 years and we still have very poor provision of care. in this particular area. So I guess what's traditionally happened is that if people are depressed or anxious, they are offered a treatment that we would give to somebody who's diagnosed with a primary mental health disorder. And I'm going to focus on web-delivered treatments because there's been lots of trials of others, because this is about remote delivery at the moment. And there's probably 3 relevant trials of more traditional CBT. The 2 at the bottom of this, and this is taken from a recent review, were small pilot studies. And they used 2 programs that are freely available in the UK. One's Beating the Blues, and the other one is Mood Gym. And what they found was that there wasn't a great uptake. There was quite a lot of dropout. Beating the Blues seemed to have some potential effectiveness, but a lot of people said it wasn't that relevant to MS. And the same, if you look at the qualitative data from Mood Gym, people found actually it wasn't accommodating to having difficulties with fatigue, poor concentration, and they didn't like the lack of human input. There was a much larger German study of Deprexis, which is a program, and it's a commercially available program largely in Germany, but there's English versions which are used in the US. And actually this looked fairly promising. It was a large trial in Lancet Psychiatry, but again, when they interviewed patients afterward, one of the complaints was, this is not taking into account my specific challenges with MS. It was useful, but only up to a point, because it's not doing that. And I guess that's been part of the mission that I've had going forward, is how do we make treatment for depression and anxiety, or what we would talk about as illness-related distress, more relevant for people with MS. So we've worked a bit with Gaia, who've done the Deprexis program, and we're currently running an MS Society. It's funded through, we actually have come to the end of it. We're now doing the follow-up with Deprexis. We've altered Deprexis to be more MS specific, and we've ran the trial in Germany, US, and UK. And we've, interesting in this program, because this is another issue in terms of how do we make these treatments available for people, is we've been comparing Deprexis on its own, which a lot of these internet programs are designed to do. In other words, you just do it on your own at home, to Deprexis with in-programming message from a therapist, which we've trained, and just treatment as usual. So we'll have those data soon to be able to hopefully share with you to see whether it works. But what's happening more specifically here in the UK context? Well, one of the things that I've done over a number of years, partly funded through the work that we've done with the MS Society, is look at how do we understand distress specific in illness. So we might get people with MS who do have a specific primary mental health disorder. So we can't discount that, and in which case some of these primary mental health treatments are very important and really helpful. But if your distress, if your high symptoms of anxiety are driven by the constant illness stress that you exposed to, and the critical events such as getting a diagnosis, illness progression, having to change your identity, having to change your roles, having to manage symptoms, stressful medical procedures, making different treatment decisions, managing your illness in the COVID pandemic, those kinds of things, actually the protocol is very different, because you need to understand it as a kind of series of very difficult stressors, and that there are ways of managing those stressors which will help return your equilibrium. So if these things instigate distress, a certain amount of distress is actually normal. So if you suddenly have a relapse or your disease progresses, actually it's normal to be distressed. We don't need to treat that. But if the distress becomes overwhelming and it's constant, then we need to offer more support. And so what we've done over the years is we've looked at all the cognitive factors, the thinking type factors, the behavioral type factors, and how we can use these to help people return to their state of equilibrium so that the distress is manageable and doesn't intrude too much in the quality of life. And I'm not going to spend any amount of time on the detail of all of this. It's a very detailed model, but I'm very happy to answer any questions of it. So in some of the early work funded through the MS Society, we did this model very specific to MS, and we developed a treatment called supportive adjustment for multiple sclerosis. And if people are wanting a treatment protocol, this is freely available from the MS Society. You should be CBT trained, ideally, to use it. But we designed this to be used in a trial with nurses. So we trained nurses in the CBT. We were trying to think about how do we get this out there, because they know hardly any psychologists within MS services in the UK. There's some, but very, very few. So we trained nurses. But it is quite time intensive. It was mostly offered on the telephone, so it can be done remotely. This wasn't a web treatment. And we did find, which we've published the trial a few years ago, that at 12 months, supportive listening was less effective than CBT at managing distress. And again, when I talk about distress, what we've done in these treatments is we combine a treatment for anxiety and depression. Rather than treating one or the other, we look at overall illness distress. So this is very promising, but at the moment it's not rolled out. And why is that? Well, One, we need to be able to train nurses. The other one is we need to ongoingly supervise nurses, because it's not, CBT is not part of what nurses do in their day-to-day jobs. It's suddenly a whole new skill they have to learn. But the other thing is nurses are incredibly busy doing nursing, doing MS nursing. So all we're saying is, there's no workforce. Why don't we get nurses to do that? Well, then we need to get more nurses. Somebody, we need resource. That's the reality. We also did a pilot. One of the things that came out of the SAMS trial was some of the patients with more progressive disease said some of the CBT wasn't meeting their needs. So we designed a mindfulness training that was specific to progressive disease. We worked very closely with people with progressive disease in this work, again funded through the MS Society, and ran a very successful pilot trial. It was a small trial. There were only 40 people randomized, but actually the results were quite spectacular in terms of reductions in distress, and also looked like they might be cost effective. And we haven't actually got funded to do a larger trial yet, but that's certainly, and this week was the first mindfulness trial to be offered through telephone. We didn't have Teams in those days. It was pre-COVID. So I think it would be a lot easier to run now. So again, it was all remote delivered in small groups. So again, I guess in terms of efficiencies, but this was run by Angeliki Bogosian, who has done a lot of work on MS as well. She was working as a postdoc at the time and is now a senior lecturer at City. But again, we need to find a way how you need to be trained in mindfulness to do this, and also trained in mindfulness specific to MS. So we have some potentially really good things, but why has not everybody got them? So where do we get to? So I've kind of changed tack in the last few years. I'm kind of moving from running trials to think about how do we get stuff implemented? How do we make sure that if we are doing things that work, that they get out to patients? So you have to think of who the potential workforce is. And I'd be interested to hear from the audience in questions on this. So I guess one is that you train existing people who specialize in MS, but not psychologists, so in CBT or mindfulness, and they take up the role. But then who does their current role? Because we know that physiotherapy is important, we know OT is important, we know nurses is important. The other thing that we can do now is look at expanding the remit of improving access to psychological therapy service. So this way around, you've got people who are very well versed in the psychological treatments, but they're not as well versed in multiple sclerosis. So they will be very good at treating mental health, but not so much in the context of long-term conditions. Now, the advantage of IAPT is that it's in every postcode in England. So in terms of being UK-centric, it's available to every patient because you can self-refer as well as be referred by a healthcare professional. One of the things that I did, I was national advisor for this program when it rolled out from 2011 to 2016. We developed a national top-up training program. So since 2017, we've been training therapists in how do you treat people with physical long-term conditions. They're also getting increasingly good at using guided web-based therapy. And the advantage of web-based therapies is you can standardize the treatment much more than you can in the more manual-based approach that I showed you. There's also new nice guidance about integrating IAPT into secondary care and primary care services. And I think we could be doing this far better in the MS world, is IAPT reaching out to the neurological services and vice versa, so that they're working together better. So in light of this, what we've done is we say, what can we provide IAPT that will help them standardize and do this job better, bearing in mind that most of their training is on primary mental health. So we've brought all our research together and worked with a group of people with long-term condition, including people with MS, and we've produced a program called Compass, Navigating Your Long-Term Condition. And the idea with Compass is to provide people with an ongoing toolkit to navigate an illness, because they're going to be distressing times in an illness. And it's no point just treating it now, it's providing people with tools for the long term. And I won't spend too much time talking because I'm running out of time, but it's mobile optimized, even though it's a web treatment. Patients can actually choose their journey in which way they want to do it. They can track their progress throughout. They also have a therapist who's their guide. And one thing that we do know, CBT works better if it's guided by somebody trained in CBT. And the guide can either use telephone or Teams, or can use in-subject messaging to provide the support. The guide has their own platform to monitor their caseload, including people, if they get too distressed, they'll get a red flag that they'll have to use a particular procedure that we use in IAPT. People fill in regular questionnaires so we can track progress, patients can see progress, and the therapists and so forth. So we're really excited about this. We've been doing some early implementation work in our local trusts, and we're currently running a randomized control trial through the charities. Shift is one of our organizations who are helping us recruit. So we're not running this through NHS at the moment because we couldn't get NHS ethics during COVID. but we are working with 4 different long-term condition charities, 2 of them MS. So we've currently got 20 people with MS recruited, and we're going to be doing a trial of about 150 to 200 people to see whether Compass is effective across long-term conditions with the view of a longer-term rollout. So I guess very briefly, just to sum up, I think there are ways that we can improve provision. I think we do need to be doing this for the reasons I've given, because it'll be cost effective, but it'll also make the lives of people with MS massively better. We've also got really good supports that Rob and Gemma are going to tell you that are already existing, and so people can make use of those. And I see this as something in addition to what charities are supporting. I think charities are doing a wonderful job of providing excellent support. I think we should routinely screen patients for distress when they come to clinics, so that we know whether we should be signposting them and so forth. And I think we shouldn't be moving towards trying to connect these services better. So I'm going to leave it at that point. Thank you very much for listening at that very whirlwind tour. But I think I'm still within my 15 minutes, and I'm going to hand over to Rob, who's going to tell us more about the exciting things that they've been doing at Shift in this area.
So thank you for the introduction earlier, Rona. As Rona mentioned, I'm Rob Sloan. I'm head of service at Shift.ms, and Shift.ms is the social network for people diagnosed with multiple sclerosis. So I'm here to give the patient group perspective to remote management of anxiety and mood disorders. I'm going to talk about, I guess, some of the left field, non-traditional means that that we help people kind of get on with this management in a self-driven kind of way, and how they kind of dovetail with traditional services as well. So I'm going to be talking a little bit about the needs as we see it. I'll be talking about our services, and there's going to be a particular focus as well on a service that we launched in response to COVID last year as well. And I'm delighted to be joined by Gemma as well on this panel, because Gemma was actually involved and intrinsic to the launch of this program, and she'll be going into PPE for the Mind in a bit more detail as well in her presentation. So in terms of the need as we see it, so Rona's talked about the prevalence of mental health and mood disorders in MS, and just to add to that, we've done a recent study about the prevalence of PTSD in MS, and actually we found that people reported that they needed the kind of most support to prevent PTSD and the PTSD related symptoms in these kind of 3 key areas that I thought I'd kind of touch on. So first of all, respondents to this study identified that diagnosis and the diagnosis process was an area where support is needed. And people reported that symptom management is an area of kind of keen need, and also around treatment decision. It's interesting to see treatment decision as a moment of trauma, and perhaps an area of need for intervention around kind of management of symptoms associated with PTSD. So in terms of our services, which is really the kind of the focus of this presentation, for those unfamiliar with Shift.ms, Shift.ms is the social network for people living with MS. It was founded by MSs, it's for MSs, and it supports many thousands of recently diagnosed individuals around the world as they make sense of the condition. It's free, it's independent, and it was set up by George Pepper, who was diagnosed in his early 20s. And when he was diagnosed, he found it incredibly difficult to find other MSs his age, even online, who were in the same situation as him, the same position. And he found that there's a real gap in support for people recently diagnosed with MS, and that's why Shift was launched. So to understand what we do as a service to complement more traditional support around the management of mental health, the first thing I'd like to do is talk about the link between social inclusion and mental well-being. So we know MS is an incredibly isolating condition in the same way as many long-term conditions. More than half of people report feeling socially isolated as a result of being diagnosed with MS. And being left alone during a time of significant change, such as a diagnosis, can test even the most resilient of us. And we believe that by combating isolation through offering networking opportunities is a great way that we can help MSs kind of maintain a healthy mind. So in terms of our services, the map that we have on our website is really the first port of call for a lot of our users. So being diagnosed, going onto our website, typing in local area and seeing all the little red dots of people in the local vicinity. Actually, people report that just seeing those little red dots is a way of having immediate positive impact on feelings of isolation and loneliness. In the same way as seeing the little red dots on the map, we have a forum of thousands of conversations, over 70,000 conversations on Shift.ms. And just seeing the fact that there's a buzz of conversation of people in a similar situation is enough to alleviate a certain amount of kind of isolation around diagnosis. And we see management of mental health in many different guises on our forum. So on top of thousands of conversations that we can actually categorize as being directly about mental health through tagging and kind of technologies like that, there are actually lots of instances of people managing their mental well-being by actively reaching out and telling their story. We find it we know that by getting a personal account of a trauma or a significant change down in writing is a powerful way to process exactly what you're going through, and it's a way to be able to recognize and perhaps even challenge unhelpful thinking patterns and thoughts as well. Sometimes the posts get kind of very angry and emotional, but that's just part and parcel of a diagnosis journey. And we find that actually on the most part, even posts that start in a very sort of angry way attracts great support from the forum. It's open as well, so there's no paywall or behind closed doors activity, and that openness leads to very kind of supportive conversations. So we know that not everyone's ready to throw themselves into a community of thousands to get the support they need to reduce the isolation that they're experiencing. And we also offer, I guess, bridging services as well. So one of those services is called the Buddy Network. So the Buddy Network is a means of an individual who's been recently diagnosed with MS to be paired up with someone who's a little bit further down the line. And the idea is, after that one-to-one support has been enabled, then hopefully that's a bridge towards group support, or maybe even through to the Shift.ms forum. So again, a way of providing accessible support for anyone, any level of confidence. So alongside the social opportunities that we provide through Shift.ms and the peer-to-peer opportunities that we believe are a great way of managing mood and emotions, we also make kind of films and short films and movies as well. So in these films, we tell the human stories behind MS and connect the science with real lived experience. And this is a still here from a series we produced a couple of years ago called Animated Symptoms. And Paula, the participant in this particular video, talks about carrying her moods and emotions around with her physically, and just by animating this and bringing her story to life helps to add context to the way that she feels about these I guess this burden that she carries around sometimes.
I'm Paola, and I'm living with multiple sclerosis. Mood and emotions, oh my gosh. Depression, anxiety. I get very, very anxious in, I'd say, social situations. I'd definitely say that since my MS diagnosis, I've found it a lot harder to be in situations because I feel like other people don't necessarily understand me and don't understand the condition that I have and don't understand the symptoms, and I feel very much like I'm carrying those invisible symptoms sometimes. And because people can't see them, I'm then aware that they can't see them, and it gives me anxiety because there are times that I don't want to be in certain situations because I just want to get home, or I'm just exhausted, or I'm mentally drained. Anxiety is what I'm still learning to deal with. I feel like I've tackled a lot of the other symptoms. I think it's all to do with mindset, and I genuinely feel like the future of me tackling anxiety will only come through understanding and building on my mindset.
We find that the films are beneficial for a number of reasons. First of all, they reduce social isolation. Just seeing someone articulating an issue or a challenge that you yourself are facing on a day-to-day basis is a great way of reducing isolation. They often spark conversations. Sometimes people won't agree with a portrayal of a symptom or an experience, and they'll say that, and that conversation might resonate with someone else, and a connection will be sparked. So reduction of isolation happens furthermore after the content is released. But also these short accounts shed light on how to describe often hidden symptoms such as anxiety, mood, and emotions. And this series of film in particular has been reported as an especially useful way to share one's experience with those around as well, so family and friends. I'd implore you to have a look at our YouTube channel as well if you get a chance. There's a lot of content on there, often around the invisible side of living with a long-term condition. So as I mentioned earlier, one of the areas that I'd like to focus on in particular in today's presentation is a program that we produced last year in response to the COVID-19 pandemic. And as I mentioned, Gemma is going to go into this in more detail as well, offering the patient perspective, and that was called PPE for the Mind. So when we look back at last year and really the challenges that have kind of washed over into 2021 as well, we found that there were some kind of key areas or key challenges presented to the MS community. So we found that there was increased isolation, increased uncertainty. There's a lot of generalized information there and a real lack of personalized information. There's also a lack of patient representation in health services and health information as well. Patients were hard to reach due to lack of freedom of movement, but also lack of resource as well. But alongside these challenges, there are also some opportunities presented. First of all, a great partnership opportunity with neuropsychologist Joe Johnson, who had developed an in-person ACT program, acceptance and commitment therapy, which was really predominantly aimed at the police force. And there's an opportunity here to convert this into a digital service. In doing so, there was a real opportunity we felt in increasing patient representation in the production of a service or content. And we were really excited about the idea of collaborative learning at the time as well. The idea that educational services are best presented when individuals are tackling a challenge or a problem together, as opposed to learning from a traditional top-down kind of expert perspective. So we wanted to combine all these opportunities in reacting to the COVID-19 challenge. So the first thing that we decided to do with this almost patient-led or MS-led perspective was to bring in 3 MSs who are central to the development of the program and the actual production of the program as well. So Zoe, Mike, and Gemma, who joins us today. So together with Joe Johnson, they produced PP for the Mind, which was a 9-episode program. It's open to anyone. Marketing was targeted towards MSs through our channels, but it very much is kind of an open access program. It's what we call a video cast. So there are some visual elements, but they used only when there's a point that needs to be communicated in more depth that's been discussed. But we tried really not to distract from the message or the kind of the audio that was on offer. And each episode features a balance between theory and exercise presented by Joe, and then conversation and reactions involving Mike, Gemma, and Zoe as well. So it took about 3 weeks from this concept being developed to the first episode being released. It was a very fast turnaround. And this was because we were operating at speed in response to prevalent need in the community. And because we released the first episode so quickly, we were forced to release what we call a minimal viable product. So something that we knew was going to be impactful, but could evolve over a 12-week period. So we learned and refined the program as we went. And this kind of approach allowed us to react to both qualitative and quantitative feedback on the episodes, as well as comprehensive viewing metrics that are available through a lot of the kind of social platforms that we're using. So we're using Instagram, our own Shift.ms platform. We were using podcast platforms such as Spotify and Apple and iTunes as well. So we're really kind of iterating and improving on the fly. So real success from the program as well was the live sessions that accompanied the pre-recorded program. And again, mentioning Gemma here. So Gemma, after going through this program with Joe and the other MSs involved, became an expert in her own right. And with her experience of digital learning design, as well, Gemma was design very much and lead in the kind of the production of these live sessions. So Gemma acted as a sort of a guide going through the knowledge that Joe had and a bridge between the community and the program that we'd produced. So a couple of quick stats. So that we've had over 100,000 views of the content and well, over 100 live session attendees as well. And around 87% of attendees reported they found the sessions useful, and 80% stated that they planned to practice the skills discussed as well. And just to round up the presentation as a whole, So 3 key points. I would say point number 1 is that time around the diagnosis of a long-term condition is key. We've found through our longitudinal studies and evaluations that our service has the highest impact around diagnosis. I would say that something core to the way we produce content and services is that we ensure that we're MS-led. And I would say that even when it's difficult to do so at times, like COVID-19, I think it's important. It's more important than ever to embed MSs in the production and delivery of services. And also on the back of PP for the Mind, I'd really push for this kind of launch and learn strategy to content and services. So going with something that is perceived minimal viable products that is going to have an impact, and then be willing to evolve and redesign and iterate as the service is out there, and not launch with something that's shiny and perfect. This is something we're trying to instill across everything that we do at Shift.ms as well. So that's it from me. And I'm sure, looking forward to hearing some questions if there are any at the end of the session. And I'm going to hand over to Gemma now.
Thank you very much. Thanks for that. So as I've already been introduced, my name is Gemma. I have MS. I was diagnosed, obviously, like I said, in 2010, and I'm a digital learning designer too. So I'm just going to talk a little bit more here just about my experience of remote management of anxiety and mood in general. Basically, what happened is that with my diagnosis, life obviously had to change dramatically. And it meant a massive change of life circumstances. At the time I was working in television, I used to work lived down in London, and was working, 16-hour days, 6 days a week, very much at a pace that I just couldn't keep up. And it took, even though I think some of my mental health issues were there beforehand, I think I was already kind of anxious, things like that. It kind of took the MS diagnosis to really hammer home that I wasn't well. One of the things that I noticed is that my anxiety went through the roof. And with the more, like I was saying earlier on about the onset of symptoms, the more those symptoms got worse, the more ill I sort of start to feel. Basically, after about 7 years of living in London, I think I then after my diagnosis, was very much like determined that it wasn't gonna change my life in any way, shape or form. I was gonna carry on. And it meant then that I was, because my anxiety, because my depression at the time, I was pushing through to levels that was just not healthy. So I was moving around the country, getting myself into a lot of debt doing that as well, trying to be able to find ways to work. I found London was not viable because of the transport system there. So I moved to Leeds, I moved to Manchester, and I kept on trying to work on it until one day in Manchester I had a massive relapse, and I just sort of went, I've got to go home. What happened after that is that I then came back to Sheffield. I moved in with my parents for a little while. And one of the things I noticed, they just said, Gemma, your anxiety is just through the roof. I found it really difficult to drive as well because of some of the symptoms of the MS. So things like my sight and my vision, I was getting diplopia and stuff like that. I was getting like quite a bad double vision. So things like driving, even if I had an eye patch on so I could drive legally, I was finding that cars that coming at me at different rates and things like that made me so much more anxious. This was all compounded and just added on to just the general anxiety as it was. So then what happened was that I went to the doctors, went to the GPs, and obviously funny you were talking about IAPT, I got referred through to the IAPT services, which was fantastic. I started to do the stress course that they do. I can't remember what it's called, but there's a stress course that they were doing, which I actually found so useful. I did it once with my parents. My parents actually came with me to come and support me on it, and also to learn some things themselves. We sat there in a big sort of open forum sort of way of working, where you sit down, go to presentations. I think it's one every week for 8 weeks. Found it really useful. Found it so useful that actually when I found the stress levels going back up again, to re-team myself back up again, I self-referred back again and went for the second time. While I was actually signed up for the second time, I was contacted by IAPT and said, look, we're also running this trial. It's a course that we're doing for people with long-term conditions. Do you want to go? And I was like, yep, absolutely. And again, that was very different. I think it was only for 3 weeks, and it was kind of during the day, but it was very interesting to be able to do that because it was very good for sitting down with other people with other health conditions that I remember thinking, it felt that level of community was massively just increased. It felt fantastic. And to be able to sit there and go through the kind of like the CBT levels of the the grief process and how to managing your systems, how to advocate for yourself and things like that over a very short amount of time, but with other people that are going through it as well. So the conversations that I was having with other people in those meetings was just as important to me as the information they were giving me as well. Then obviously life gets in the way, and I had a massive, my aunt died basically, and it made life so much harder. My anxiety went again, skyrocketed to the point where I couldn't kind of catch it, and my depression skyrocketed because I couldn't catch it. And I remember going to the doctors and saying, look, I'm really not very well. I was already on antidepressants. She said, right, go and see a talking therapist. I managed to get onto talking therapy. So I've now actually, this is what makes me laugh, is I've kind of been through all those different ways into mental health support that Rona was actually talking about earlier on. I've done them all. But I went to go to talking therapy, and the talking therapist was like, you are so wound up that even the talking therapy is not kind of helping. I'm going to send you to CBT and I want you to come back to me. In the end, I never went back to her. But as you all know, the access to these sort of services on the NHS can be quite limited sometimes. You've got a certain amount of time. They said to me, I'll be out there probably about 8 weeks and I'll be finished. A year later, I was finished. That is how much kind of untangling it took of it. And one of the things I found out about that was that what was really driving that anxiety and driving that that depression was my loss of identity. I was working in television. I was a high achiever. I was going to push myself and become this person, live in London, live this life. And all of a sudden that was not happening. And without that, I had nothing else. I couldn't think of anything else of who I was. My identity had completely gone. One of the things that CBT helped me realize, though, is that identity that I was aiming for and I was achieving was not even one that I even liked. It's not even one that I wanted. It's not one I wanted to do long term. And it was just all about kind of rebuilding and changing those thought processes into what it is I actually want to be and who I want to be. So having said that, I've been through quite a few of the different ways and means of getting, of improving your mental health through my MS. One of the things, however, that I found is the most helpful on top of all of that has been my allotment. And I want to put that out there because that's a very different intervention almost. It wasn't even an intervention. I think it was just an idea that I thought of it'd be quite fun to have, but it has worked out to be the most important thing kind of that I've done. This is because it is, to me, it's a mixture of all the things that I was taught and all the coping mechanisms that I was given, and a way to focus it, and also a way to sort of let out all that sort of anxiety and things like that within my daily life. The picture in the background of here is my actual allotment. It was a mixture of things like grounding that I was doing while I was there. There's a lot of mindfulness and just being outside and being open in the open, doing a lot of exercise, the sense of community, making friends, things like that. It just hits on all sort of levels, and that's why I think that sort of thing would be a really good intervention. It's kind of the thing that I always say to people, anyone anywhere with varying levels of disability, with varying health conditions, things like getting an allotment will help you so much more than you think it will do. So that's just why I put that up there. And obviously there was a thing in the Guardian recently that was saying that it's official that having allotments good for your mental health. Well duh. So just quickly, just to go into my involvement, I've got notes down here as well. So with the PP for the Mind, I was initially asked to take part, and like Rob said, it was a very, very fast turnaround. We were actually asked to record it all over 4 days with Fiona. I think it was 4 days in the end, and they were kind of 4-hour sessions. And what was really fun and difficult about that is that from my point of view, from mine, Zoe's and Mike's point of view, it's almost like we're having really intense therapy sessions being squashed into a very short amount of time. There's a lot of realizations there, a lot of things to ruminate on, a lot of things to think about and to process, and then to give your feedback on in a very, very short amount of time. Each podcast was probably, did say there's 9 altogether, isn't there? And I think each podcast works out at about an hour of our time into, about 45 minutes of our time into each podcast. So imagine that's quite a lot of time that was spent on them. But the output of that, though, obviously, I remember my has to go away and edit them and all that sort of thing as well and make them fantastic. But the output of that, I think, is by far a really, really good resource that is really, really valuable. So the time put into it, although it's quite short, and it's quite heavy at the time, the output is just, I think, will be usable for sort of a much longer period of time for people to use, just as a resource. Yes, and then the live sessions were that I was approached to do was just that I think Fiona was going to do them with me, and then there was there's a couple I've done with other people, either MSs in the community or with people that are experts in their field, where we talk about and we go through a little bit more of the practicalities of what people can do. So it's all very good having these podcasts, but people need reminders and they need the impetus to do it right there and then. So one of the things with the live sessions is that people come along and we actually do it. So like, for example, we did one recently with Susan Carey, where she was talking about exercise and endorphins and how to lift your mood and things like that and how it works. And she had me actually doing actual exercises and got other people around the world all involved at the same time. It's fantastic. It's a very cool experience. And then just my last one, just from my head as a digital learning designer as well, I just want to go through a few things of why I think that PPE for the mind really works. My first thing is that I really love about it is that it has an analogy running through it, and that analogy running through it is like a storyline. The storyline being that, you know, imagine that you have been kidnapped, you're in the back of a bus, you can't see anything, you can't move, your arms and legs tied up. And then you go through the analogy of releasing yourself from that, to finding your sat nav, to working out where you need to go in, to checking out what is serving you in that car, to then going on your route and getting to your destination. That analogy, that story, and that storytelling really helps to bring people into it. It's a often used sort of pedagogic way of making sure that people are engaged and really into the storyline of what it is that's happening. I think that works really, really well throughout the podcasts. It really helps keep people engaged. I think the use of real people in the stories, I think there's quite a lot of things that I see at the moment that are quite dry because they are being delivered by healthcare professionals to you at home. And I think having seen someone go through it and ruminate and reflect on something who's very much in your position. So MS has seen other MSs, or at least other people with neurological conditions, seeing us three talk through those things and be able to put them into our lives and into our perspectives is a really powerful way of understanding what that means. And making out just, yeah, it's another really, really strong pedagogic tool of making something feel familiar and not therefore then othering. And then my last one is obviously about accessibility. For me, the brilliant thing about the podcast is that they are accessible to anyone really with the technology. I know technology can be a massive barrier, but these days, in this day and age, there's quite a few people that have, access to phones, access to laptops, access to your television, smart television, things like that. You can log into different places and be able to get this pretty much anywhere. It's obviously accessible. It's in English only and things like that. I can imagine that it could be like things like putting in things like transcripts would be good, so that people can then move them over to different languages if their first language isn't English. But for the most part, it's a very, very accessible platform and a very accessible way of being able to get that information. And then the last one is also just around it being very practical. It gives you actual meaty things to do. It's not just being spoken to, it's saying, right, let's sit down, let's go through this process together. Let's look at I'm trying to think some of the practical things we did, and I can't remember any of them right now because of course I can't. But there was stuff like doing a reflection through what it is that you want to achieve and how you want people to see yourselves, that you can sit there and we actually go through how to do that in the podcast. Things like that I think really lend to that learning, and then lend to the resilience of the people then that take part, so that overall then it's just a much better experience. And that is it from me. That's literally it, just my little rumination there at the end. Thank you.
Brilliant. Thank you so much, Gemma, and Rob. You've been so spot on with your timing. It makes my job as chair very easy. And I, Gemma, really important reflections on your journey. And the thing that really struck me was your statement of when your anxiety and depression, when you couldn't catch it. And I think that's a really lovely way of putting it, because I think it comes back to what I was saying, in a way that actually depression and anxiety are normal, in the context of a lot of difficult things. And you are faced with a lot of difficult things with MS. And so there's lots of good ways to manage that, but it's when it gets away that's the time of reaching out for professional support. And you've obviously been incredibly good at doing that. And one of the questions that's going to come up, I think, is around that. So I'll raise that. So, you know, thank you very much for those great insights of your own experiences. So thank you very much for the questions. I'm going to have to hop off quite promptly because I've got another call at 5. I'm going to go through these. I'll answer what I can and then open up to Rob. But I believe that Rob actually can stay on a little bit longer if needed. So if the discussion's carrying on and I disappear, you've got other people here to answer it. So just to really start at the top, Ruth Strauss, thank you very much for your comment. And I think you're sharing your experience there about needing more neuropsychology and being in the community, and that you are reaching out to your IAP neuro service, which is great. And you know, I take your point that you're gathering evidence for the funding, but it's not easy. And you're right, it is hard. And I think we have lots of good models for what we should be doing, but in practice, it is very hard to get this integration going. And part of what we wanting to try and do and sell to commissioners is kind of where it's happening well. These are model services, and how can we move? But all services have different challenges. Some are better funded, some have people really fast spread out, and so forth. So it is going to be challenging, and we're finding the same in the implementation work that we do. But I think we've got to keep going because it's so important to do that. And I think you were saying any top tips on how to engage with the commissioners. I guess one of the tools that I do use is that report that I mentioned, which is the King's Fund report around the kind of cost benefit of doing better into what I call integrated care. So that, you know, we have these very divided services where we look after people's mental health and physical health separately. But actually, if we really want to provide care for people, you actually should be the two things together. Because even if you give people drugs and medicines, how their body responds to those things is going to also depend on how healthy and other things that they are. So I find it very strange that we even think that these things should be offered in kind of separate ways. So I think it's just banging on about it and presenting data, and you definitely have to present data. And one of the success stories, I guess, of IAPT has been the data. So what IAPT did incredibly well when it's set up is that they keep outcomes of every single person, and Gemma can tell you how tedious it is, I'm sure, but you have to endlessly fill out measures in terms of your mood and your impact and your satisfaction with the service. But that is why IAPT has grown, and it has grown every year, and it continues to grow because IAPT goes to the politicians and says, we meet our targets, this is what we're doing. So in the service, if you're wanting to talk to commissioners, keep data would be my other question. And I know it's not easy in stretch services, but keep good data and good outcomes. So I don't know whether Rob or Gemma, you want to add anything to the thought about talking to commissioners, if you had any thoughts.
I was just going to talk to your last point there about keeping data, and I think that was a challenge that we faced with PP for the Mind, in that we wanted to create something that was completely open and accessible to all. But in doing that, I think you touched on kind of drop off the digital services earlier on in your presentation, Rona. It was very hard to then get any idea of follow up in a lot of that content. I think the elements of the program that were really successful in evaluation and collecting data were some of those closed or the live Zoom sessions that we were able to host. But a lot of the evaluation that we were doing was purely based on uptake of content, so engagement over time and that kind of thing. So that was a learning process for us as well, along the kind of the course of releasing those episodes week by week. But in terms of kind of converting that to commissioners, I would agree. I think it's just about knowing what you want to collect from the very beginning, and making sure you've got a clear way of doing it, and designing the digital tools, whatever platform you've got, to be able to do it in as succinct a way as possible. Through PP for the Mind, what we tried to do as well was we've often relied on longitudinal studies, and we've had huge drop-off rates on those studies through just sending it out to service users over time. So we tried to challenge that and really send concise questionnaires, and that had moderate success, asking 1 or 2 questions after engagement, and really kind of taking advantage of people's immediate feelings of sort of reward or getting something out of that experience. And And we're only able to do that by having a really focused idea of what the key priority of what that content was set to do and achieve. So yeah, I think it's about just when designing, thinking about evaluation from the start and working out what you want to present back to commissioners.
Yeah, I think that's true. We've done the same with Compass, where people regularly fill out their anxiety and depression scores, and it's actually, you can use it so that the program uses it as feedback, as well as so that you're getting the data, but people are also getting feedback.
Yeah.
Way. So it's trying to use your data in creative ways. And I know one of the things that our local trusts have done is they now try within services to routinely screen people using GAD and PHQ, which are free to use measures of anxiety and depression, and they're well recognized and standardized, so that everybody who comes into our acute trust is meant to fill out if they want to. They don't have to, but like you take blood pressure and all the other routine things, we now measure anxiety and depression. And so even if some of the services are reluctant to do that, say, well, what are we going to do with all these anxious, depressed people? We've nowhere to send them. But actually, if you say, how else you're going to create the argument that you need more services? And so if you can even start to document the fact that people are coming in with higher levels of distress, and go to commissions, we're not treating this, and therefore we're not doing our job as well as we can. So even if you can't look at outcomes, at least do the assessments at the beginning, because they actually don't take long. Those self-report measures can be completed in 5 or 10 minutes.
I just wanted to touch on what you said there about users getting something back from submitting data as well. Like, so often you see services seeing users as an ATM almost, and just asking and asking and asking. But if you're able to I guess personalized services on the back of any data ask, there's a huge incentive there. So yeah, I would completely agree with that.
Great, thank you. And just checking, Philip, you were asking for Philip Seddon. I think you were asking for how to get the SAMS manual. I think I answered you. I hope so. I'm not sure if I've got my head around the table. I sent the link to the MSS side. If not, I can put it in the chat as well. But Hugh will have it now anyway, so he might be better. He might be more tech savvy on this particular Zoom platform. I also wanted to pass over from an anonymous person, Rob, saying thank you so much for all that Shift MS is doing, and particularly over the last year, because it's been so crucial. And I know that because we're working with a number of charities on our Compass trial at the moment, that the number of calls to charity support lines have really escalated, and charity support has been so important at this time. And I know it's been so difficult for charities with funding as well. So really hats off to all the amazing things that you have done. I would really second that. Now, Nick Hartigan is asking if anybody knows of any research that's been done into MS's priorities for therapy. We certainly, all our work is based on qualitative work. So all of ours is based on developing therapies that patients tell us that are helpful. But I can't say that we've necessarily looked at very specific, is this number one, number two? I don't know if Shift has, Rob. I mean, I know you've obviously picked up the PTSD, which I thought was really interesting.
Yeah. I think other than when it's significant at the time of greatest need around diagnosis, say around perhaps symptom management and treatment decisions, I think we haven't ourselves done any kind of real research into understanding the actual kind of priorities in terms of therapy. I'm kind of reading that as, is it type of therapy or is it just general needs? But in terms of the work that we've done, it's been very much focused at when it's needed at this point. But it'd be really interesting to find out kind of more what lies behind that as well.
Yeah, I was going to say, I've have a look into that as well, and I've not found any really big, robust research into what the priorities of therapy are. I think it's a little bit, as and when you ask for it a little bit, it's a little bit patient-led and a little bit more circumstances-led, at certain times when you walk in and you need it, it can be there. But what those priorities are, whether or not we can preempt them, whether or not have them ready for you, and have access to that and start pushing access to that right really early, I think that's a little bit there as well. That's not happened, unfortunately, and I have tried to find it. I am, like I said, an information eater, and I can't find it.
Yeah, that's interesting. I mean, one thing about individual therapy is, I guess, is part of the formulation is trying to work out what it is, but it is sometimes difficult. And I think one of the things that we have found, again, is that some therapists don't put the illness necessarily at the heart of that. And it will, because they're much more experienced at putting the anxiety or depression at the heart of it, because that's what they're trained to do. And that's kind of what we're trying to shift a little bit, talking about a shift MS. We're trying to shift a little bit, therapists putting the illness first and the depression and anxiety as a consequence of that. But that is quite a shift for some therapists to do. And Mohammed, I see you, I think you've raised a really interesting question here about depression is not just the accepted, and you're quite right. If people accept that they are struggling, it's a lot easier in terms of referral. And I'm going to answer this and then hand over to the others, because I think there's different ways to look at it. But yes, you will get people who you think are really distressed, but that they're denying it. And I suppose the way I deal with this is, and it's a way that I've been trying to kind of also shift some of the thinking within mental health, is not to see it as a mental health problem, because then you label people with another diagnosis. Now, for some people, that's fine, because then it says, oh, this is what I'm dealing with, and therefore this is the treatment. For other people, it's like, oh, I've already got one diagnosis, don't give me another one. And they also feel misunderstood, because they're thinking you kind of label, because there is still the stigma. There shouldn't be, absolutely shouldn't be, but there still is for some people, the stigma around being told they've got a mental health problem. So I often tend to present as, you know what, MS is an incredibly challenging thing to deal with. And at some time, most people kind of reach out and need to get a bit more support. And, you know, I was just wondering if right now that might be where you're at or something like that. So rather than saying, is you depressed, it's putting it in a way that the illness is challenging. So that's something that I would think about. But Gemma and Rob might have other thoughts on that.
Well, I was going to say, I think it's, I know we're not an all-out mental health kind of service, but it's this consideration we have around designing digital interventions, is that even the first point of signing up to a service like Shift.ms is a point of acceptance, and seeing any kind of initial engagement with services as such. And that does drive the way that we think about the services we design, and those early intervention points. I think one of the interesting things about sort of patient activation acceptance is that if individuals take a first step and are overwhelmed or aren't engaged with what they find and are knocked back, actually they're in a worse position than they were when they started off. So I think anyone designing kind of interventions that offer people perhaps in, you know, around a time of trauma or a diagnosis, I think really need to take that on board and think about sort of the longer term management of a health condition and the impacts that first interactions can have.
I think that's a really good point. Gemma, did you want to add anything?
Nothing really to that. I think I just that I agree, really. I think there is a thing about, especially like I say with my story earlier on, is that I couldn't accept at the beginning. There was too much going on, like you were saying, Rob. It's not the best time, it's not at diagnosis. It was definitely later on, once I'd had to accept because of life circumstances. I get it. It's very, very difficult to accept that something is not quite right and that you need help, and therefore then access that help when you're in that. So yeah, that was literally it.
Great, thank you. Now there's a couple of queries specifically for you, Gemma, about the podcast, but because I've got to pop off soon, I'm going to answer one that's perhaps directed at me, and then I'm going to hand over to you and Rob, if that's okay. Rob, if you're happy to keep sharing. So I guess, Margaret, thank you for that great question. What do you like to see in a good referral? I suppose one of the things that is helpful, number one, is an idea of that this is not, as I kind of mentioned, this is not necessarily a mental health problem or diagnosis, is that we would really like to offer you more support, and these people might be able to do that. And also letting people know that through the assessment and discussion, you'll kind of jointly agree what the best approach is. The other thing that is helpful is if you think that it's predominantly the MS that's driving the distress, I think it is worth, particularly because I tend to be very protocol driven around, is this panic, is this phobia, is this a kind of diagnosis, is actually to let the person know in the referral note that I think this person is struggling with the adjustment challenges of MS, and it might be good to focus the therapy on that, so that you kind of put the illness at and again, it will depend, because some people might have a mental health diagnosis anyway. So it is a little bit making decisions around that. The other thing that I think is helpful is perhaps saying to people as well is understanding the mind-body links. I think it's becoming more part of what we talk about, but the understanding that actually treatment it really should be around tackling both keeping your mind and body healthy where you can, because actually that will generally help you do better in the longer term. I mean, there is certainly increasing evidence, it's not necessary, we haven't pinpointed exactly, but you know that ongoing stress and stuff is unhelpful in terms of longer term disease trajectory and so forth. So those would be kind of my main tips there. I see there's a question around ACT. There's probably been more mindfulness trials than ACT trials. So again, it's to do with where the best evidence is. It's not saying that ACT won't be helpful. ACT certainly probably is helpful. I think just to kind of reassure people is that I know sometimes people are majorly, it should be ACT rather than CBT. If you look at the trials generally in the literature, both ACT and CBT tend to work. So some of it might be people's preference really, rather than saying you have to have one versus the other. So hopefully some of that's helpful. It's been a real delight to talk alongside Rob and Gemma today. Thank you so much for the help. I'm really sorry I'm having to leave before it's all over, but it'll give Gemma and Rob a bit more of a voice. So thank you so much, everybody. And I'm going to drop off and join my next one.
Okay, so I've just spotted a couple of questions I think we can answer directly, and we'll see if any more kind of come in just while we're answering those. So first of all, there's a question for Gemma about the podcasts, Nick. So where can the series be accessed?
Yeah, I was going to say it's as Rob was saying, it's kind of all over the place at the moment, isn't it? So if you literally go onto Spotify or any of your podcast platforms, you will search for PP for the Mind, you'll find it on there. But equally, if you just go into Google and search PP for the Mind in there, it will take you straight as well to the ones that are actually housed on the Shift MS website that you can access as well without having to log in. So anyone can get access to those. And again, if you want to go to YouTube and put in PP for the Mind there, it'll come straight up as well. So basically, any of those platforms, pick one, anyone, PP for the Mind, it'll pop up.
Great, thanks, Gemma. Apologies, Nick. I think Rona might be in best place to answer your question about further clarification about areas of work. But perhaps we can pitch that question to her, and we can share it along with the content. In terms of PP for the Mind being adapted for carers of people with MS, I think ACT therapy, CBT, I think could very easily be kind of personalized, customized for any potential audience, perhaps even topic area. I think one of the really interesting things about the program is that in its current form, yes, we can kind of look at new audiences, but it's also incredibly responsive to new needs and topic areas that arise in the community. A huge kind of fall off from COVID has been work and employment, and we're increasingly looking at the format of PP for the Mind and kind of putting the spotlight on that area with specific needs, and seeing what kind of tools we can develop with the framework that we've already created to address that.
Yeah, absolutely. I was also going to say as well that a lot of the content of it is quite, like I said earlier on, it's quite based on actual work done, so actual practical applications of different tools and things like that. So, and they're immediately shiftable from whichever audience you're talking to. They're not MS or specific. They are tools to be used by anyone. It just happens that we use them as MSs. So certainly, yeah, it could be adapted for carers of people with MS. It could be adapted for people with other long-term illnesses. It could be anyone with it could literally anyone can do it, and that's what is kind of the really strength of it as well, because you can use it then for people even with MS that it's not the MS that's the kind of the issues why they've come to it. It could be something else that's triggering their mental health difficulties.
In fact, it was quite well. It was an interesting process, because a lot of the conversation that occurred in the original content that we produced, even though it sprang off the back of the need presented by COVID, the conversation tended to go straight into issues that actually anyone might experience day to day with employment, with work, with lifestyle, and MS sometimes featured, often it didn't. It was the day-to-day anxieties that come naturally to most people. So yeah, it's an incredibly flexible format, I think.
Cool.
The final question is around access to Compass. So I don't actually know the answer to this one. Gemma, I don't know if you do, but I
don't.
So we might have to pitch that to Rona as well. Well, hopefully we'll be able to find the answer to that. I don't know if anyone will be able to type in the chat whether it is or not, but yeah, I'm sorry that we can't directly answer that.
Yeah, I think wasn't Compass though that's not the trial that she's doing, is it? That she's
yes.
through it, yeah. So I don't know if it is, I don't think it is by referral then. I think it's more of a case of getting onto the trial, I think, probably through you guys at Shift. We can certainly answer that for you, though, and we'll send it out to you with additional information. Hi, Nick. You've got a question. I'm a clinical psychologist and director. I also have MS. I'm running some training for our psychologists about working with MS. Could I share this recording? So the recording of this, of your account, was so helpful. That's absolutely fine with me. I will leave it with the others to just agree that that's fine. I know that obviously I work in digital learning, copyright is law, but for me, that's absolutely fine. I don't mind sharing my account as definitely like a full agreement for that.
Great. Well, I think that's it. That's all the questions. So I guess the last thing to say is thanks very much for joining us today. Thanks to the MS Academy for having us, and Gemma, thank you. And yeah, it was great to hear from Rona as well earlier on.